Morning, everyone. My name is Captain Dana Poloni. I'm from Eisenhower Army Medical Center, and today I'll be talking to you about operative time tracking for umbilical hernia patients. This was a quality improvement project that was performed via retrospective review. It was inspired by issues that arose from scheduling seemingly straightforward umbilical hernia repairs into shorter time slots, and then having our scheduling system preventing us from doing so due to erroneously considering these procedures to be lengthy in nature. I have nothing to disclose. Some Army MTFs use a surgery scheduling system, or S3, to schedule OR cases. Each OR is given approximately 7.5 hours of total time for daily use. This includes anesthesia time, case time, and turnover time. In S3, the surgeon's operative time is defined as when he or she makes the incision and ends with turnover back to anesthesia. In regards to scheduling, the operative time is the main determinant in predicting the case's length of time. Cases are scheduled into S3 based off the historical procedural time, or HPTs. HPT is calculating using the Olympic average of the 10 most recent cases, and then it drops the highest and the lowest OR times and then averages out the remaining 8. If a surgeon has less than 10 total cases, then S3 will use the average of whatever cases are available. And if a surgeon has never before performed a specific procedure, then S3 will use the department's average. HPT will include the total time from a case with multiple procedures if no individual case breakdown is available. For example, if a case involves a sleeve gastrectomy, a hiatal hernia repair, and an umbilical hernia repair, and there's no delineation made between the beginning or end of each one of those individual procedures, then S3 will take the total time for all the cases combined and then use them for each individual HPT. In reality, S3 has an inflated sense of how long some of these procedures should be taking. Especially for umbilical hernia repairs, which hypothetically should be less than 1 hour. This can be frustrating when you're attempting to schedule an umbilical hernia repair into a time slot or an OR that has available space, and then you're prevented from doing so because S3 thinks that will put the OR over time. The overinflation of case time leads to underutilized operative space, and this results in longer wait times for patients to receive treatment. This, of course, can be modified via human intervention, such as calling the OR scheduler or having anesthesia rearrange cases based off of their familiarity with case times. However, this can be time-consuming. So the objective of this study was to identify what factors lead to increased operative times for umbilical hernia repairs at Eisenhower, and then ultimately how to work within the constraints of S3 to produce more accurate HPTs. So this was a retrospective review that pulled data from S3 for all open umbilical hernia repairs between the dates of January 2013 and June 2018. Alternate centers were used to identify certain patient characteristics. Some of these characteristics included age, gender, BMI, ASA classification. Case characteristics were also identified to include hernia defect size, the use of mesh, and the acuity of the case. Additionally, information regarding certain personnel was also pulled to include resident level and the presence of a student registered nurse anesthetist. A total of 201 patients who underwent an open umbilical hernia repair were included in this study. Among these patients, the majority of them were males. Approximately 20% of them required a mesh repair. The average OR time was around 71 minutes, and the average defect size was about 2.6 centimeters. The table on the left demonstrates that during the initial data analysis, umbilical hernia repairs that were involved in cases with multiple procedures had a significantly longer OR time. This data was then removed as it was regarded as an outlier. The table on the right references solitary umbilical hernia repairs. Of the aforementioned variables, increased ASA level, a history of prior abdominal surgery, the use of mesh, as well as the size of a defect were all associated with increased operative times. Additionally, the presence of a registered nurse anesthetist, or student registered nurse anesthetist, was associated with a shorter OR time. So the use of mesh was identified as a target for intervention because the nature of a mesh repair is inherently different from the nature of a primary repair, and it's one that most surgeons are aware of prior to proceeding to the operating room. This also falls in line with the significant increase in OR time associated with the size of a hernia defect. Most surgeons will attempt a primary repair for defects that are less than 2 centimeters, and defects that are greater than 3 centimeters typically warrant a mesh repair. So in January 2019, new S3 procedure names were introduced. These included umbilical hernia repairs with and without mesh. During this time, the general surgery department was encouraged to communicate with OR personnel as to when they were done with a portion of a multi-case procedure, so as to record more accurate HPTs. This table shows a comparison of individual staff surgeons' procedural times for all open umbilical hernia repairs before the new S3 name changes and then after. Grossly, there appears to be a significant difference, but this difference is not significant. We suspect that the more these new procedural identifiers are used and as higher case volumes are accumulated, the more significant the difference will be in case times. As at the time of this data analysis, most staff surgeons had less than 10 total cases with each of the new procedure names. So the purpose of this study was to specifically identify which factors influence operative time at Eisenhower Army Medical Center. A literature review corroborates the finding that larger hernia defects are associated with longer OR times. And this study has taken that association and found it to be true even for smaller hernia repairs, including umbilical hernia repairs. Our data suggests that for an even more accurate decision-making and resource allocation, it is possible that these procedures may need to be further differentiated into separate categories based off of their defect size. Umbilical hernia repairs that were done in conjunction with other procedures are unlikely to be statistically significantly longer. Rather, it's more likely that the S3 system is using limited data to create false assumptions. Residents are a known factor to increase operative time when compared to attendings alone. However, the discrepancy between intern and a chief resident's operative time was surprising. This could possibly be due to the higher level of acuity and the more complex cases that higher residents are involved in, and it could also be due to interns being involved in cases with attendings being more hands-on. So moving forward, the data collection and review of the new S3 procedure name changes will continue to be analyzed. We'll also investigate whether with multiple procedures will include a distinct individual procedure times or they will include one total time. Additionally, as we extend the scope of our investigation to include all ventral hernia repairs, both open and laparoscopic, our preliminary data is suggestive that it may be more efficient to schedule a hernia repair based off of its hernia defect size rather than its abdominal wall location. It will be interesting to see the new Genesis EMR, how it will handle average case times at Eisenhower Army Medical Center, as many of the cases are scheduled with CPT codes. Regardless, neither S3 nor Genesis take into account the size of a hernia defect. Likely, it will be that umbilical hernia repairs will need to continually possess separate name changes for open or with and without mesh. Thank you.